Great, thanks so much. And thank you so much for inviting me and also to those who have joined us sort of virtually. I actually get to set the stage today to sort of what we are going to think about here from a very exciting sort of program to really think about great research that's going on in pediatrics and also what's happening here within Canada. Just to give you my disclosures. I think one of the things that's so interesting about transplantation is that it really does have very unique challenges. And this is just an editorial that recently got published, a commentary in Lancet. And the reason I thought it was important, I'm just going to highlight some of the things that we think about, is that this is really an exciting time in transplantation, that there's really great excitement thinking about xenotransplantation and what's happened. Also, the ex situ organ machine perfusion has really changed what we currently do quite a lot and how we think about transplants and what we think we can recover in terms of the transplants. And a lot of that work has been happening in Toronto with lung and kidney, and it's been really exciting to see. We also recognize that use of organs and tissues for research often pose a complex and unique ethical challenges with inconsistencies between legal frameworks globally. And that really has made it quite challenging to do some of the work that we want to do. And after many years, we continue to fight for this, but organ donor registries should be expanded to include consent for research and include consent at the time of donation, because it's really important that we understand all the things that we need to make sure that we can do at the time. And it needs to be really an open conversation with families at that point. We also need meaningful partnerships with both researchers as well as patients in thinking about how do we integrate all the patient and public perspectives, how do we communicate about information, and how do we make sure that there's equitable opportunities for everyone. And lastly, a lot of this work has happened through multidisciplinary cross-country consortia, and I think we just need to keep on developing that further and further, because transplantation, even though we in ourselves and the lives that we live think it's quite common, it is still a rare disease that happens. So specifically in pediatrics, what are the issues? Well, on the left-hand side, this was an editorial that was written in Pediatric Research in 2023, and it talks about like all the factors that actually impact health overall on the left-hand side. And then what's happened on the right-hand side is sort of all the regulatory groups, or really the people who are impacting all of this kind of work. And I think one of the things that when we think about pediatric health and trying to maintain pediatric health, I think one of the things we have to recognize is when we take care of children, we're taking care of them for their lifetime, not just taking care of them for the 18 years they might be seen in pediatrics. And we have to recognize that they may not get comorbidities that happen during childhood. They may not have multiple diseases except for their one leading to end-stage organ disease. But as they get older, they're going to continuously get exposed to multiple different factors, both genetics, environment, and social factors that lead actually to poor health and worsening disease. And one of the things that we also think about is actually what's their adult life going to look like, and how can we keep their adult life healthy and free of disease. And so these are things that actually on the adult side that they don't really think about, right? They're usually treating people acutely, managing them, trying to get them over that hump. The median age on dialysis in adults is actually 65. And so often people don't think about this lifelong trajectory, whereas we need to think about it in pediatrics. So many of our patients and families remind us about how we need to think about 10, 20, 30 years down the road. So what's the evidence that we can use to actually support some of the work? And you're going to hear about different types of evidence today in different areas. But on the left-hand side is the common sort of framework we use as we teach epidemiology, we teach, what's the best science? Really, the best science, we think, are randomized controlled trials. But in the adults, we all often have enough data that we can do systematic reviews and meta-analysis. But much of what we do in pediatrics tends to be case controlled or case series and case reports, because we treat a relatively small disease that's quite rare. The other thing that was interesting was less than 60% of pediatric RCTs are actually ever published, which is really disappointing, because even if it's a negative trial, we need to make sure that we get that information out there. So the more that we can do pediatric randomized controlled trials, we should do them. And what's interesting is that mixed trials with adults and children tend to do a little bit better. Again, but we need to think about making sure that we don't have a publication bias and that we're getting them published as soon as possible. And what I think is that really we're going to think about, and you're going to hear about biomarker or deep phenotyping that occurs in patients. And this is just an example that I give in nephrotic syndrome, but on the left-hand side of the top figure, you can see, I think if I show my arrow, it does show up on screen. So on the left, these are our patients. If you do deep phenotyping, integration of biomarkers into clinical trials, we actually may be able to strategize who should get care and ultimately think about long-term remission. And if it was a transplant patient, we think about long-term without any evidence of rejection and long-term success. And ultimately, what we're thinking is that if you're going to have these kind of trials, you'll end up doing standard of care. And then hopefully we'll set up platforms that we can start bringing in different treatments, similar to what we did for COVID. And I think ultimately these umbrella trials based on biomarkers is really going to be the way to go. The other thing that we think about also is sort of this one-size-fits-all approach. And this is quite common in adult management of patients with chronic disease, where we're giving them one therapy and then we're deciding, do they have an adverse event, no benefit or benefit. But what we've seen now is that, and we talked about this a little bit at our dinner last night, was that SGLT2 inhibitors are considered the statins of the 21st century and are really life-altering. And we think that this actually may be a transformative medication within transplantation and maybe something that they should all get it. And it may be that it is a one-size-fits-all. What's interesting about it is that it has been shown, this was in Nature Communications actually just recently, and they actually took patients through a large data set and said, let's see who's already on an SGLT2 inhibitor compared to those who are a kidney transplant recipient. And you can actually see in this one study about almost 4,000 patients that there was a benefit, a lower risk of all-cause mortality, of cardiovascular disease, of kidney disease, even going on to dialysis. And so this is actually going to be, I think, the way of the future, and that there are medications that will transform how we take care of patients that are not just about the immune mechanism, but definitely have some benefit and metabolic effect within the kidney and also in the heart itself. I think what will happen is that we'll think about more stratified medicine. So we'll think about this one size fits all. But what you're going to hear about today is, what do you do when you've got well-characterized cohorts? What do you think about social determinants of health? And what do we think about biomarkers? And can we actually stratify populations a little bit more? Because ultimately our goal is really precision medicine. So we not only take care of the person in front of us, but we're actually taking care of their health issues. And we're thinking about what's their genomics, what's their health history, what are their medical records, and hopefully can really make sure that we're giving the best medication for the right reason for the right patient. I'll just digress to think through what else is novel that's coming forward. So we think about precision medicine. Traditional RCTs are one way to go. And David's going to talk to you about the trials and tribulations of conducting an RCT. But there's also called target trial emulation with observational data. And this allows you to use data that's currently available. And you can actually have longitudinal follow-up over decades to be able to understand how drugs compare to each other. So this is what a study design can look like. So a cohort study where patients get enrolled in a study and you're following them over time. You're taking data that's already available. A target trial emulation means that you do the same thing, but now you assign when they get the drug at time 0, and then you follow them over time. And versus a randomized control trial, which you're treating them, you randomize them, and then you have this outcome assessment. And usually you have multiple assessments. What we've actually shown, and this has just been accepted for JAMA Pediatrics, is that by doing target trial emulation, you're able to take studies that may be very biased, like on the left, when you take a look at observational data, and you're not comparing apples and oranges, you're really actually trying to compare Macintoshes to a Gala apple, I'll say. And what you're trying to do is make sure that you're trying to compare those children who are getting a drug and decide what's the likelihood that they would both be prescribed the drug and control for all those factors. And when you do that, you actually get the comparison of the drugs on the right-hand side, because now you've mimicked a clinical trial. And so this is actually what the outcome is that there's no difference between cyclophosphamide and calcineurin inhibitors from the time of giving this drug for nephrotic syndrome. And I can see down the road that this is what we'll start doing in transplantation, because we know when children receive a drug, and we'll be able to follow them longitudinally over time and be able to understand what's the overall success. The other thing that we need to think about is that there's very little data in thinking about longitudinal outcomes. And there are some studies that take a look at transition in the US. But what we've done within Ontario is really, and I think it can be done nationwide, is that we've taken children and compared them to children who didn't receive a kidney transplant and taken a look at who's been at risk of diabetes or who's been at risk of cancer. And I'm not going to go into the details, but you can see the bottom line shows you those who never received a transplant, and those who did receive a transplant always do much, much worse. Logarithmically, logarithmically much, much worse than those who are non-transplanted. And this is important because it's important that we recognize that these are outcomes that happen 10, 15, 20 years down the road. So diabetes and cancer. We've also done one here on the right of cardiovascular disease, again, 10, 15, 20 years down the road. And so what's important is that we're now putting all this data together so that we can actually follow children longitudinally and understand what is their greatest risk. Is it from diabetes and heart disease? Is it from cancer and then cancer-related therapy? And what are the things that we can do to mitigate their long-term risk? Notwithstanding that we need to treat their immune function and prevent rejection, but we also need to think about what happens over 10, 15, 20 years. And this is an example on the left that shows that your cardiac structure and function from dialysis actually get much, much better after you've been transplanted. So transplant really is the way to go, but having studies that go more than 10 years is really critical. So I just sort of set this up to really talk to you about that trials are the best evidence to support children. I think especially novel targeted therapy. Emulated target trials, I think, are going to be the way to go, especially in pediatrics, when we cannot do trials in every single drug. You're going to hear about biomarker-driven strategies, longitudinal studies, and I think children deserve to have much more evidence-based data to support our ongoing care in question. So just to help set it up for today, what you're going to hear is at the keynote is that David's going to be talking about randomized controlled clinical trials. And then during sessions 1, 2, and 4, you're going to hear about different types of study designs that have actually shown which markers are going to be helpful and actually thinking about prediction of outcomes. And then in session 3, you're going to hear about patient-reported outcomes, patient-centered outcomes, and knowledge translation from Samantha Anthony. So I'm hoping today that we're really going to talk about building the evidence and really learning about what's new and novel in pediatric transplant. Thank you.